Welcome to the deep dive. Our goal here, well, it's pretty simple, really. To transform source material today, it's a key pharmacology chapter about endocrine drugs into knowledge that, actually sticks. And today, we're zeroing in on a tiny gland with massive power, the thyroid.
The little butterfly in the neck. Yeah.
Exactly. It acts as the body's master regulator, driving metabolism, growth, energy, all through T3 and T4 hormones. Our mission for this deep dive is really digging into the drugs that manage the two big extremes. Too little hormone, hypothyroidism, and way too much hyperthyroidism.
Right. And maybe before the drugs, just a quick baseline on how it normally works.
Good idea.
Okay, so the thyroid grabs iodine from your diet mostly and uses it to make T4, that's thyroxine, and T3, triiodothyronine. Now, T3, that's the powerhouse. It's like 4 times more potent biologically than T4.
4 times. Wow.
Yeah, and their production, their release, it's all controlled by TSH, thyroid stimulating hormone, which gets its signal from the pituitary gland. It's a whole feedback loop.
So the goal with any drug therapy here is getting the patient back to what we call euthyroid, right? Normal function.
Precisely. Euthyroid is the target.
And we're fighting 2 main battles. Hypothyroidism, not enough hormone. And hyperthyroidism, sometimes called thyrotoxicosis, that's hormone overdrive.
Exactly. And just quickly on causes most hypothyroidism, the vast majority is an issue right in the thyroid gland itself. We call that primary hypothyroidism.
Okay.
Hyperthyroidism, on the other hand, is very often linked to Graves' disease, which is an autoimmune thing. Knowing that helps understand why we either replace hormones or try to suppress them.
Okay, let's start with hypo. What happens when things slow down? What does that feel like for someone?
Well, the body basically goes into energy-saving mode. Symptoms are pretty broad but noticeable. Feeling cold all the time, gaining weight without trying, fatigue, real crushing fatigue sometimes, and even depression.
Sound miserable, like wading through treacle.
It really can be. And it looks different depending on age. In kids, if it's severe and untreated, it's called cretinism. And that really highlights how vital T4 is for development. You see delayed growth, low metabolism, and unfortunately, intellectual disabilities. Shows why screening and early treatment are so key.
And in adults.
In adults, the term is myxedema. You get the weight gain, the fatigue, hair loss, low stamina, but also some distinct physical signs, like a firm edema. It doesn't pit when you press it, and the skin can get this sort of yellowish, dull look.
Okay, so that's the slow grind. What about the flip side? Hyperthyroidism.
That's the engine completely redlining. Metabolism just skyrockets.
So instead of cold, they're hot.
Exactly. Debilitating heat intolerance, rapid weight loss even though they're often eating more, diarrhea, anxiety, terrible sleep problems, and the heart takes a real beating, palpitations, risk of atrial fibrillation, just feeling constantly irritable and on edge.
It sounds intense.
It is. And there's a critical complication we have to mention. Thyroid storm.
Okay, wait, let's pause there. Thyroid storm, that sounds serious, not just fast heart rate. This is an emergency.
Absolutely a medical emergency. It's like all those hyperthyroid symptoms suddenly explode, often triggered by something like stress, an infection, even surgery.
Right.
You get extreme high fevers, racing heart rate, maybe even heart failure, because the heart just can't keep up. It's life-threatening. Untreated, people can die within, 48 hours.
Okay. That really puts the need for treatment in perspective.
Yeah.
So let's pivot. How do we treat the deficiency, the hypothyroidism?
The mainstay is replacement therapy, giving back the hormone that's missing. The go-to drug is synthetic T4, levothyroxine. You probably know it as Synthroid or Eltroxin.
Why that one specifically?
Well, it's chemically pure, identical to the T4 your body makes, so the effects are really predictable. There are natural desiccated thyroid options, like from animal glands, but levothyroxine is generally preferred for consistency.
Makes sense. And how does it work? I mean, obviously it replaces T4, but what does that do systemically?
Right. It replaces T4, which the body can convert to T3, and this boosts the metabolic rate everywhere, increases oxygen use. But the cardiovascular effects are really key. It actually increases the number of beta-adrenergic receptors on heart muscle cells.
Hang on. So it makes the heart more sensitive to adrenaline, to catecholamine.
Exactly. It sort of primes the heart to respond more strongly to those fight-or-flight signals.
Huh. So that sounds like it could be risky, especially if someone already has heart problems.
It definitely is. That's a major reason why it's contraindicated. You wouldn't give it to someone who just had a heart attack or someone who already has hyperthyroidism, obviously. The approach, especially in older adults or those with heart disease, is start low and go slow with the dose. Because if you overshoot, if you give too much hormone,
What happens?
the most significant risk is cardiac dysrhythmia, irregular heartbeats that can be, frankly, fatal.
Okay, this brings us to a really critical safety point you highlighted earlier, the dosing. Levothyroxine is dosed in micrograms, mcg.
Tiny amounts.
And this is where things can go catastrophically wrong. The potential for error. Reading mcg as mg, that's not a small mistake, is it?
It's a 1,000-fold overdose, 1,000 times the intended dose. It turns a daily maintenance medication into something potentially lethal. It's one of the classic, really dangerous med errors.
Just terrifying. And you mentioned its pharmacokinetics make this even trickier.
Right. The pharmacokinetics, how the body handles a drug, are really unique here. Levothyroxine has a very long half-life. We're talking 6 to 10 days.
So if someone takes that massive overdose today,
it stays in their system at dangerously high levels for over a week, maybe longer, even if they stop taking it immediately. The effects persist.
why so long? What keeps it around?
It's highly protein-bound. It latches onto proteins in the bloodstream very tightly. Think of it like a reservoir that slowly releases the drug.
Okay.
And that high protein binding also means big trouble for drug interactions. If you introduce another drug that's also highly protein-bound.
Like warfarin or something.
Exactly. Or certain anti-seizure meds, they can compete for those protein spots, knock levothyroxine off, and suddenly you have a flood of free active hormone in the blood. Instant toxicity.
Wow. So understanding that protein binding isn't just academic, it's crucial for preventing sudden hyperthyroid symptoms from drug interactions.
Absolutely. It dictates how we manage patients on multiple medications.
Beyond the major cardiac risks, what are the more common signs that the dose might just be a bit too high day to day?
Basically, any signs that look like hyperthyroidism creeping back in. Feeling nervous or jittery, trouble sleeping, heat intolerance, losing weight unexpectedly, tremors.
Got it. And you mentioned interactions. We talked protein binding, but anything else specific?
Yeah, it enhances the effect of oral anticoagulants like warfarin. So you might need to lower the anticoagulant dose to prevent bleeding. And it can decrease the effectiveness of digoxin, a heart medication. Always need to check compatibility.
Okay, let's switch gears. What about stopping the thyroid when it's overactive? Treating hyperthyroidism?
Right. So here the goal is to suppress the gland, or in some cases, partially destroy it. The main drugs we use to suppress it are the antithyroid thiamide derivatives. The two big ones are methimazole, also called thiamazole, and propylthiouracil, which we usually just call PTU.
Thiamides, okay.
Yeah.
And other options?
Yeah, there's radioactive iodine, I-131. The thyroid actively takes up iodine, so you give a radioactive version, it concentrates in the gland and selectively damages or ablates the overactive tissue. Surgery to remove part or all of the thyroid is another route.
But focusing on the drugs, methimazole and PTU, how do they actually slam the brakes on hormone production?
Their main job, their mechanism of action, is to block the enzyme responsible for incorporating iodine into tyrosine. Tyrosine is like the backbone molecule for thyroid hormones. No iodine incorporation, no T3, no T4 synthesis.
So they stop new hormone from being made.
Exactly. They inhibit the formation process.
Is there any difference between methimazoles and PTU and how they work?
Yes, there's a key difference with PTU. Both of them block that synthesis step within the thyroid gland, but PTU has an extra trick.
Oh.
It also inhibits the conversion of T4 to the more potent T3 out in the peripheral tissues, like in the liver and bloodstream.
Ah, so it works in two ways. Blocking production and reducing the activation of existing hormone.
Precisely. Which means PTU can sometimes provide a slightly faster reduction in active hormone levels, which might be beneficial in severe cases, or like thyroid storm.
Okay, but faster or broader isn't always better. What are the downsides? The adverse effects?
Well, the most serious ones are liver toxicity and bone marrow toxicity. These aren't common, but they're dangerous.
Bone marrow toxicity, what does that lead to?
It can cause a granulocytosis. That's a severe drop in certain white blood cells, the neutrophils, which leaves the patient incredibly vulnerable to infections. It can also cause general leukopenia, low white cells, and because it can interfere with vitamin K, it might increase bleeding risk, hypothrombonemia.
Wow. So infection and bleeding risk, those are major.
Definitely. Other side effects can include things like skin rash, maybe loss of taste, muscle aches, but the liver and bone marrow are the big concerns we monitor for.
Which brings us to, well, the elephant in the room, pregnancy. You mentioned earlier how vital thyroid hormone is for development. What happens if someone needs antithyroid drugs while pregnant?
It's a really difficult situation, honestly, because these drugs do cross the placenta.
Meaning they can affect the baby's thyroid.
Yes. They can potentially suppress the fetus's own thyroid hormone production, leading to goiter, which is an enlarged thyroid, or even hypothyroidism, like cretinism, in the newborn.
But untreated hyperthyroidism in the mother is also risky for the pregnancy.
Exactly. It's a balancing act. If treatment is absolutely necessary, the goal is always the lowest possible effective dose to minimize fetal exposure. There's also some debate about which drug is preferred. PTU might be favored in the first trimester because methimazole has a slightly higher association with certain birth defects and maybe switching later. It's complex, requires specialist management.
Okay. Really highlights the need for careful consideration there. Let's talk practicalities. How these drugs are actually taken. Timing seems critical.
Oh, timing is absolutely key for both types of drugs, but for different reasons.
Let's start with the replacement, levothyroxine.
Okay, for levo, the rule is take it once daily, consistently, and crucially, on an empty stomach. Usually about 60 minutes before breakfast is the standard recommendation.
Why so strict about the empty stomach?
Absorption. Food, especially things like fiber, calcium, iron, even coffee, can significantly interfere with how much levothyroxine gets absorbed into the bloodstream. Taking it on an empty stomach ensures more consistent, maximal absorption.
And taking it in the morning, is that just convenience or?
It helps prevent insomnia, too. Since it boosts metabolism and energy levels, taking it at night could interfere with sleep for some people. Morning dosing is generally preferred. And patients need to know this is usually lifelong therapy. And they generally shouldn't switch brands without talking to their doctor and getting retested, because even small differences in bioavailability between brands can throw off that delicate balance.
Okay, lifelong empty stomach, first thing in the morning, don't switch brands.
Yeah.
Got it. What about the antithyroid drugs, PTU and methimazole?
Opposite advice there. Those should be taken with meals.
To help absorption.
No, actually, to reduce stomach upset, they can be quite irritating to the GI tract, so taking them with food helps buffer that.
Makes sense. And diet plays a role too, doesn't it? Especially with the antithyroids.
A huge role. Patients on antithyroid drugs like PTU need to be really careful about avoiding foods that are high in iodine.
What's that?
Because iodine is the raw material the thyroid uses to make hormones. The drug is trying to block iodine uptake and use, so if the patient is flooding their system with extra iodine from, say, iodized salt, lots of seafood, soy products, even some supplements, it can basically overwhelm the drug and make it less effective.
They're working against their own medication if they eat high iodine foods.
Pretty much, yeah.
And for the levothyroxine folks, any dietary things besides the empty stomach rule?
Yes. The big one is spacing it out from known binders. Calcium supplements or calcium-rich foods, iron supplements, even high-fiber meals. They need to take their levothyroxine at least 4 hours apart from those things.
Because the binders will just grab onto the hormone in the gut.
Exactly, and prevent it from being absorbed. Flush it right out. So timing relative to meals and specific supplements is critical.
This monitoring aspect seems fascinating. You're not just looking for the original symptoms to come back, but you're also watching out for signs you've gone too far the other way, toxicity.
That's the tightrope walk, exactly. With levothyroxine, if the dose is too high, you're looking for those hyperthyroid signs we talked about: palpitations, nervousness, weight loss, feeling hot, maybe insomnia.
So you're watching for the opposite condition.
Right. And with the antithyroid drugs, the toxicity monitoring is different. We're watching for signs of those serious adverse effects, especially the bone marrow suppression and liver issues.
What are the absolute red flags? The things a patient needs to report immediately.
Okay, for someone on levothyroxine replacement, any new chest pain, palpitations, or excessive sweating needs immediate attention. That suggests the heart is being overstimulated. For someone on antithyroid drugs like PTU or methimazole, the critical warning signs are things like fever, sore throat, mouth sore signs that could indicate a granulocytosis, that dangerous drop in white blood cells, or any unusual bruising or bleeding, which could point to clotting problems, or jaundice, yellow skinnies, signaling liver issues. Those demand stopping the drug and getting checked out right away.
That's vital safety information. What about specific populations, older adults, for instance?
Yeah, older adults are a key group. They tend to be much more sensitive to the effects of thyroid hormone replacement. Their metabolism is often slower. Liver and kidney function might be reduced.
Meaning the drug sticks around longer or has a stronger effect?
Both, potentially. So the general rule is they often need a lower starting dose, maybe 25% less than a younger adult. And you increase the dose much more slowly and cautiously, always watching for those cardiac side effects. The risk of adverse reactions, especially heart problems, is just higher.
Makes sense. Start low, go slow, especially in older patients.
Definitely.
Okay, so to kind of wrap this up, we've covered a lot. Replacement therapy aims to restore normal function by acting like T4. Antithyroid therapy tries to inhibit hormone production.
That's the core, yes. Replacement versus suppression. And both require really careful management, meticulous monitoring, and importantly, patient understanding and adherence to get it right. Maintaining that euthyroid state is the goal, but it takes work.
And thinking back across everything we discussed, pulling from that chapter material, what's the one big takeaway for you, for the learner listening?
For me, especially looking at levothyroxine, it's the profound importance of understanding the pharmacokinetics. That long half-life, 6 to 10 days, combined with the high protein binding and that incredibly narrow therapeutic window, it means that errors, especially that horrifying myxedema to milli 1,000-fold overdose potential, aren't just momentary blips. They have serious, prolonged, potentially fatal consequences that can last for weeks. Understanding why the PK isn't just theory, it's the absolute foundation of safe practice with this drug. It prevents those critical mistakes.
That's a powerful closing thought. The why behind the rules is what saves lives. Well, thank you for joining us on this deep dive into thyroid pharmacology. We definitely navigated some complex territory today. And thank you, our listener, for being a part of our little last-minute lecture family.